It's working. There we go. Hello, everyone. We're just coming up to the hour of 1 o'clock here in beautiful British Columbia. It's been phrased many ways, but in the springtime, it's a hard place to be. After my nearly 40 years living on the prairies and growing up there and training there and working there, the spring comes earlier here, which is a wonderful asset. We get all the 4 seasons, but we don't get quite as long a winter break. I remember the one year we were in Hudson Bay and we were almost 8 months of winter, which is a long time, no matter how you slice it. But there's something rejuvenating about spring. My favorite seasons, I think, are spring and fall. Mm-hmm. Fall's a high energy time too, and it's always the harvest, which is a big deal in the prairies, of course. So welcome everyone. This is our multiple recording. We're of course doing this twice a week currently on this Facebook Live podcast, and we really appreciate you folks turning up. Some of you will be new today, and welcome to those. To the returnees, very much welcome for continuing to follow us. It's now an opportunity now where you might share it with other people if you think you have people within your group that are home. We, of course, realize it's still somewhat a captive audience because we're all very much cocooning at home, so to speak, looking after ourselves unless we happen to be in essential services. And hats off, of course, to the people in the healthcare front line, particularly those working hard in the public health realm to give us guidance. It's cheery because I think in May, I'm hoping that we can get some semblance of normalcy back. I know it's percolating forward a lot in the United States, isn't it? It's half a dozen different places. So just before that, I want to, of course, I'm Bill Code, and this is my colleague, Christina Mitz. And Christina has worked with us nearly 2 years now as a therapist for Taymount Canada, and is now helping me very much with my information components as we continue to expand the Dr. Bill Code website to newsletters and different features. And also as a venue for those that aren't into Facebook, you can send your friends there, drbillcode.com, drbillcode.com. And then, of course, that's a place where you can purchase the book, the audio book, as well as the ebook, right? Not everybody realizes that there's an audiobook. It takes a lot of hours of dictation to do that, but it gives a nice rendition for those people traveling. And the other part I want to do today, I've given you a little more focused title in some ways than we've done previously. I think everyone's getting more attuned to all the issues with COVID. My title today, of course, was COVID-19, coagulation, CCSVI, I will talk about that, headache, and MS, and possible solutions. So my goal today is to tie all those pieces together for you and said, why would he talk about such a disparate group of things? And of course, they tie in, just as many things have tied into our talks on the microbiome and the oral microbiome and how those are huge in your immune system optimization. Today, we're going to give you other particular pieces of information and then even some suggestions as to how you can optimize your long-term well-being. Because the goal, of course, here is to empower you to use the components that I have learned, whether in integrative medicine or functional medicine or in knowledge about the microbiome, and other pieces, because it's been a huge difference to my journey with my MS and my headaches. And, I think this is what partially your hook is.
Exactly.
To work with those, to optimize your own personal health.
Exactly. Yeah, that's been a big motivator for myself.
And, the first step is us recognizing that. Many of you are there already, and some of you are just nudging toward it. And sometimes it takes a wake-up call, and I would call COVID-19 a big wake-up call for many of us, because never have we changed our lives this much for this short period of time. And it feels like a long period of time to some people. I get that because it's really difficult to not have our regular contacts and not be able to hug other people and all these other issues within our changes. So COVID-19, one of the more prevalent things that's starting to turn up is the issue of coagulation. Mm-hmm. Because when coagulation goes awry, those are the people who do quite poorly. It was made evident a little bit this week in the news because there was a young man, an actor on Broadway from Ontario, and he ended up losing his leg, as well as having a very challenging time in the intensive care. So what is coagulation? Of course, most of you know that it's blood clotting, and it's a very much a teeter-totter within the body, optimal clotting to not enough clotting to bleeding and all those issues. Up until 20 years ago, the main focus within regular medicine was let's look after those people that are problem bleeders. So it's recognized now probably 30% of the whole population has a challenge with their coagulation. So 5 to 7% of that is a bleeding problem. And of the 5%, that's mostly people with hemophilia due to factor VIII deficiency or von Willebrand's. And so those of you that have those know about them. But then it became more obvious in the last 20 years that there's often a problem with too much coagulation. And so the forerunner or the first step in that extra coagulation is fibrin deposition. So fibrin, think of it as little tiny microfibrils that the body makes of protein, okay? And it has these throughout the body. And then when the cascade is kicked in, so you cut your finger, it bleeds, two things happen. Initially, hopefully there's a platelet plug, so a whole bunch of platelets teaming up together and then contracting down to plug it. And then over the next 2 or 3 minutes, the coagulation cascade kicks in. And now the fibrin is all joined together and bound into a group by thrombin. So those, it's getting a little complex already, I get that. But I want you to think first of all about that fibrin, because that's the piece that we need to make some difference to. And as we're able to do that, it makes a difference, because in COVID-19, the people that hit the door of the hospital, and in major centers now, they're doing a couple of blood coagulation tests on them. That might be something called dimer, or in the old days, we called it PT, PTT, and those other features. But if it's very high right at the beginning, that's a high risk zone. That person's going to have a challenge in the ICU, and they're going to have a challenge the whole deal. So I want to go back a bit about that whole topic and say there may be components that you can make a difference. Okay, so who's at more risk with COVID-19? We know if you have your pre-existing conditions, okay? Hypertension, heart disease, heart failure, chronic obstructive pulmonary disease, obesity. Those are the big ones now. We've even taken asthma off the list because they do pretty well. As long as their asthma is controlled, they tend to do pretty well. But the other groups, not so much. So how do we start to tie these pieces in? Well, we know that anybody with a chronic illness, so 95% of people with a chronic illness have too much fibrin formation. So these little microfibrils are around the body, and they're all through the blood vessel tree. And so there's many, many miles or kilometers of blood vessels in the body. The key ones for supplying oxygen to the tissues are the microvasculature. And these are the 5 to 100 microns, okay? And 100 microns is 0.1 millimeters, so it's really tiny. But that's where the extra fibrin is. And the extra fibrin gets dumped there over time and creates almost a sludge along the blood vessel, a sludge of fibrin. And just 1 micron thickness of fibrin on the inside of that blood vessel reduces by 80% the amount of oxygen that's able to go through it because it hugely increases the distance. And of course, oxygen diffuses once it leaves the hemoglobin and has to diffuse through the plasma, the liquid of the blood, and through the blood vessel wall. The blood vessel wall is called the endothelium. And this, in a tribute to Joan Beal, because she talked about endothelial health very importantly for years. Well, this is a new piece that we've come to learn. I was at a superb conference, of course, online in Seattle on March 27th, and it was Dr. Ann Corson from Philadelphia area in Pennsylvania, was what's the big deal about coagulation? And she did a superb talk, and it was well presented, and it's a place where healthcare professionals, you might think about getting that. And we'll put a link on so you can look at that. Put a link certainly on my website, Dr. Bill Code, because that's where the money meets the road. So remember I said almost everybody with a chronic illness has an excess of fiber. So we need to deal with that because I just told you it interferes with blood oxygen transfer. Okay, so the extra step we also know is that if you have an acute or chronic infection, so the chronic might be Lyme, it might be mold issues, could be candida, or some other chronic infection, urinary tract, or acute infection, which would include COVID-19, okay? Each of these ramp up also the fibrin deposition. So we need to somehow bring that fibrin deposition back into optimal or closer to normal, because it's going to impair how we do. The suggestion that I have, and there isn't any papers to back this up, but this is just kind of talking in the pathophysiology continuum. If you've already got some fibrin sludge inside your vessels, you're probably going to be more compromised when you get an acute rise. All right. And that's why we're going to talk a bit about enzymes, breaking that down toward the end of the discussion. And I'll even give you a couple examples on the screen, because those you could take now on a prophylactic basis. Okay, so let's tie in the other piece. So let's go in first to CCSVI. So this is partly a tribute to the people that followed me very much on Facebook, probably at least 1,500 people for over 10 years, because I was the, maverick. I was the rare physician in Canada. There's probably a dozen physicians at least had the neck vein angioplasty treatment of their veins. And I had mine in 2010, but virtually none of the rest of them were willing to talk about it. I think they were worried about what their medical peers thought, or whatever the term was. So as a partial tribute to all of you who signed on with me at that time, and you also know that I was moderately quiet on Facebook for a lot of those years, but now it's become a really good tool to help empower you to change what happens. So CCSVI stands for chronic cerebrospinal venous insufficiency. Okay, so what it means is that the blood draining the head and spinal cord has a relative blockage on the way out. It's not a complete blockage. Everybody in medicine knows the near complete blockages. That happens in a cancer or something else, and all of a sudden their veins all engorged all through their face and everything else. I mean, that's really obvious. This is a much more subtle than that. This is a relative slowing down. So consequently, it's most commonly, and that's why I'm pointing at my neck, in the jugular veins. There's one on each side, right beside the carotid artery, of course. And it's often at the valves, which is in the region just above the collarbone or clavicle. And that's usually where the problem happens, although some of it happens in the azygos vein, which is kind of the gooseneck vein, which is in the chest. Okay, so that one's harder to look at and less people know about it. But those three veins make a really big difference as far as drainage from the brain. And it's position related, and there's all those symptoms that fit in with it. I bring it up because it's still kind of on the back burner. It's continuing to be researched. There is some centers in the world you can still get the treatment, although it's less and less common. I'm embarrassed to say that, right from here in BC, where I live now and where I lived before in Saskatchewan, did one of the so-called definitive studies on this reported in The Lancet, which was seen as the death knell of treatment of CCSVI. Unfortunately, they skewed how they did the presentation of data because they took an ellipse, an oval shaped, and then they measured it pretty much, I think, on the narrow part of the oval. So that really doesn't give you a good estimate as to how much flow there is, although they intimated that was an accepted method, even though it was a brand new method of doing it. So all those critiques aside, it still exists. I had a treatment for it in 2010 in California with Michael Arata. I had another one in 2017 in New York, Brooklyn, really, with Dr. Sal Scofani. And neither one of those are doing that procedure now because of a whole series of complicated political concerns. So move that aside, it made a big difference for me because it seemed to dramatically reduce my headaches, improve my bladder function, improve my fatigue, but it tended to dissipate mostly in 6 to 12 months, which was disappointing to me. And in reviewing the subject on the weekend, there's a paper came out fairly recently out of Buffalo, New York, showing what was the 5-year follow-up. And the 5-year follow-up showed not very much difference, not really any difference between the people that had treatment, people didn't have treatment. However, remember, I just said 6 to 12 months, because the blood vessels in the neck could be interfered. We know that the collagen changes so that there's been a marching on of blood vessel injury, a bit like atherosclerosis, which can happen in the veins as well as the arteries. But I would suggest also maybe one of the features has been this fibrin deposition over time, which has interfered with these people. The other corollary to it is now I think we can do some of the same by adding more oxygen at the front end. So when I sleep now, I'll at least have 2 to 3 liters of oxygen on a nasal specs from an oxygen concentrator, and that will boost the oxygen when I'm laying flat. And most of this problem has been when people lay flat because the jugular veins are the primary return out of the brain when you're laying flat. When you're sitting upright like now, not so much.
Yeah. Can I get you to clarify? So you got the CCSVI, and it seemed like the results kind of tapered off after 6 months, or they were reduced after 6 months. So do you think that's because you have this fibrin deposition again because the underlying inflammation is still occurring?
Well, it's one of the possibilities. We know that if you do pictures of those people, some of them will recur. So if it happens within a day, it's probably literally the elasticity of the vein, squeezing back in again. And that's why, there was different procedures or different pressures used to expand the veins, especially at the site where the valves are, because that's the dominant area, but not the only area. And my feeling now is a piece of that may be the fibrin problem.
Right. And
the fibrin problem is one that we can address now because we know a lot more about enzymes helping break down the fibrin pathway and making it happen. So, you ask a really good question, and actually I haven't invited people to, but I'm would be really excited if people ask questions as we go through this. And because my glasses and I can only do one thing at a time, I'm going to get you to read those. So if there's a reasonable question, we'll try and stop and go into it.
Yeah, well, we do have questions, so we can, whenever you're ready.
Yeah, well, before I take it on to the next step, why don't we see which questions we have so far?
Okay, so we have a question from Sherry. She says, I have MS and transverse myelitis. The last few weeks, my balance was good, and then as of this point, when I walk, now I look like I'm drunk, and I have a lot of brain fog. Any idea as to why this could be? I've been doing a lot of walking, close to 80,000 steps in a week, just look for some input.
Yeah. So congratulations, first of all. You're doing more than that kind of optimal 10,000 steps a day. Exercise wins all around. You know, it's better for our circulation, it's better for our muscles, and it's better for our brain because it increases blood flow in the muscles, but it also increases it in the brain. Also, exercise increases brain-derived neurotrophic factor, you know, which is one way to increase new neurons and more connections between our current neurons. All of us with MS, because I have it too, would really want that. So you're doing part of that really well. I suspect what's happening, several things are happening. There may be a peak in the relative inflammation in the brain. Anytime there's inflammation in the brain, and everybody agrees, even the neurologists agree, that MS is an excess amount of inflammation in parts of the brain, and it's also a leakage of the blood-brain barrier. So let's tease that apart a little bit. The blood-brain barrier, of course, is the lining of the blood vessel, the endothelium. Back to Joan Beale's favorite word, endothelium, okay? If the endothelium is injured or not doing well, then that blood-brain barrier breaks down. And now more inflammation will happen, and it kind of compounds the issue. What does that mean? Well, if we take it back another step, that is more likely to happen if there's not quite enough oxygen there. So when we were talking about CCSVI, one of the studies that I liked best about it was done by Ivan Petrov in Bulgaria, because he did sampling of the jugular veins of their carbon dioxide as well as their oxygen and their oxygen saturation before he repaired the veins and had better flow. And he found, of course, in virtually every one of his people that they had a relatively low oxygen in those veins above the problem site, and they had a relatively high carbon dioxide. And when they opened it up, those resolved. So if you take that back a step, because the reason the area that happens with MS is the longest distance from the heart, traveling through that blood vessel pathway, and the longest distance is where the injury tends to occur with MS. That makes sense if you think about it, because on the last part of that journey, oxygen is being taken off to other sites. So now there's very little left right at the end of the pathway. So if you can either up the oxygen at the heart by putting in more through the lungs, or if you can improve the flow through that whole tube, then you're going to have more oxygen left. And so that's the crisis, and that's suspect what is happening for yourself. So now you're getting relative hypoxia, and as a consequence, neurons, which are the most, challenged right with heart cells to being the most oxygen energy requiring cells in the body. If they don't get enough, they don't die, but they shut off or become idling neurons. And so then you and I experience brain fog, inability to think, more MS symptoms, maybe more bladder problems. Okay? So short-term boost for that, you could again do that oxygen at home. And oxygen at home is a good idea for COVID. There's no question. I've got at least a couple of people that have been able to help stay out of hospital because they've done oxygen supplementation at home. They've monitored it with the pulse oximeter. I found on the weekend, because I was working with some other colleagues, the Canadian Integrative Medicine Association physicians that are interested in trying to put forward something. And if you go back to the WHO, their HU document in sort of mid-March, which was a SIT-REP, I think it stands for Situational Representation number 41, they said people should have more pulse oximeters and they should have access to supplemental oxygen. Okay, so that was a recommendation out of WHO in mid-March, which is kind of interesting because now they're doing it here on Vancouver Island to watch people at home. They've got a pulse oximeter for them, and we've talked about oxygen before. But that are immediate things that you might do which would help remedy your problem. In a perfect world, if that isn't enough, then you would get a non-rebreathing mask, and I've shown pictures of them before, but it's got a bag on it, and that will get you up to nearly 50% oxygen. To do 50 or even up to 70% oxygen, if you did that a couple times a day, you might remedy your concerns. And if that isn't enough, then some of you will benefit by going on to hyperbaric oxygen. But that's another topic of another day.
Okay, good answer. So we have Penny and Warren, who've both had really great results from CCSVI. Penny says it's been 10 years since her treatment and she's still doing well. So that's great. Seems like different people have different responses,
Sure,
I suppose. Roger says, I have beta thalassemia. I just did a Google search, thalassemia and fibrin, and the top hit was a coagulation study. On a trip to Oregon, I met a woman with beta thalassemia who is convinced that it played a part in our ME or CFS. What do you think?
Well, ME, myalgic encephalitis, or chronic fatigue syndrome, depending which side of Europe or North America you're talking about, probably the same illness, very much a mitochondrial problem, okay? The mitochondria are not making enough energy. So that consequence, you feel super drained because the mitochondria, which are the little power centers inside the cell, up to 1,000 in a cell, easily, and very prevalent in the brain, because remember, the brain needs a lot of energy, okay? Something has made them so that they're not working. There's no question that repeated series of hyperbaric oxygen and now photobiomodulation will make a difference. And I suspect because these are relatively chronic problems, it's likely that the fibrin deposition is part of the issue. So if you've got some fibrin deposition, there's relatively less oxygen diffusing through the blood vessel lining or the endothelium, then you're turning down the oxygen availability. Mm-hmm. And mitochondrial function is based on two things. It must have the oxygen, and it must have the energy source, which could be glucose or it could be a fatty acid. So sometimes it's transport of one, sometimes it's transport of both. But I would suggest now these are much more reversible chronic problems than they ever were before.
Mm-hmm. Okay. Tessa says, I have been thriving since my CCSVI, but my doctor won't prescribe oxygen to me even though I have a concussion from an MVA. Is there any other option to obtain oxygen in Alberta that you're aware of?
Well, in Alberta, I do know for a fact that you can obtain hyperbaric oxygen in both Calgary and in Edmonton, okay? And you're going to have to pay for it yourself, but the advantage of that is it's a lot easier than trying to get the hoops of our regular system providing it, because it's just not in the wherewithal of knowledge yet. I watched Professor James write his incredible book, Oxygen in the Brain, The Journey of Our Lifetime, and it hasn't shifted as many people as it has. I was lucky enough, it shifted me. So the other option is you can often buy an oxygen concentrator online, okay? Because someone has end-stage lung disease, they've bought one, they've used it, they pass away. The family sells it on, the terms are all different. We've got Use Victoria, we've got Kijiji, and I'm sure there's lots of other variations.
Yeah, I did, when I was looking for mine, I did come across some online on Craigslist.
Yeah. Mm-hmm. So that's another option because you don't need a prescription for those, okay? Otherwise, you need to have a consenting physician. And due to lack of knowledge, not all physicians will go there. One option is you can try, purchase a copy of my book, Solving the Brain Puzzle, because there's a lot about oxygen use in there. The other thing that's getting more accepted in Canada, although it's not as big as it is in Europe, is the use of oxygen for headaches. And we're going to talk about that in a minute because that's how I'm going to tie in headaches partly. Okay? So there is oxygen available, but it isn't easy, and you're going to find a consenting healthcare practitioner to help you out with it.
Okay, that's all the questions.
So let's all go on from there. So we had COVID-19, coagulation, which we've partly introduced and covered, and then we had CCSVI. And once again, I really appreciate those, and it's tremendous that you're doing better, because I've seen friends of mine, they couldn't even swallow optimally. They were ready for a feeding tube, and they're now 10 years later, and they're still doing fine. So, and there's no doubt in my mind, it made my face pink almost right away. It's still pink. I still don't have cold hands and cold feet. So there's a whole host of things going on there. One of the other pieces may be the fibrin piece. So listen as we talk about the other parts. So then I wanted to talk about headache and MS. So I'm not sure which way order I put it on the sheet. Let's talk about headache first, because headache is really common, and it's really common in MS. Up to 70% of people with MS have headaches as one of their symptoms. Some will put it down at 35, but it's still way beyond the normal amount. In addition, migraine headache, much more common in women. So is MS. Maybe you're starting to see some possible reasons why as we talk about this. The other new news about headache, though, and I put a chapter on headache in my book because I'm now 40 years in with headaches, migraine headaches. I don't like them one bit, and I have a lot of sympathy for people with them. So headaches, over half of them now are recognized to be microembolic. So that means a small emboli is going to a part of the brain which may be triggering the problem. Once again, more common in women, much more common in those with what we call a patent foramen ovale. So that means that the chamber closure between the two upper parts of the heart, the atria, is intermittently open or continuously open. What that means is that an emboli, which happens somewhere in the body, maybe it formed in the legs, pelvic veins, goes up to the heart and then inadvertently can now go directly from the right side of the heart, where it's returning in the venous system, over to the left side of the heart, and then directly up to the brain or another part of the body. And that little clot is primarily based often on fibrin. Sometimes it might be a microemboli based on fat from a mild injury. It can be enough even to trigger MS and even occasionally to trigger death. So it's that patent foramen ovale is part of the issue, and this has been researched, gone on, and sometimes 60 to 80% of those people will improve if you put a patch on that patent foramen ovale. In days of yore, we had to go in and do open heart surgery and put a patch on. Now it's done through an intravascular, it's a little bit like an umbrella to close open that space. So by closing that off, you dramatically reduce the headaches. Well, that's pretty exciting. Mm-hmm. In fact, I wanted very much, it's tricky to find. I haven't been able to find any literature talking about the incidence of patent foramen ovale in MS patients. But it's my theory that it's one of the contributing features. Not the only one, but one of the contributing features for MS. And if we could find that out, put the patch on, well and good. But today I'm going to give you what I think is a medical solution for some of the same, and that is reducing the fibrin, because that will reduce the little microclots that occur, and that will reduce your risk of the headache and possibly your MS recurrence. Okay? So that's where it all starts to tie together. So that brings in the headache piece. Headaches are the bane of our existence. We've got migraines with auras. We've got migraines without auras. And if you look at migraines in the population, it's nearly 20% of the population. It goes up closer to 40% if you take away one of the multiple factors of migraine, then all of a sudden it's up even higher. So these happen a great deal. They happen really often. The patent foramen ovale is in 20% roughly of the population. But if you look at people with headaches, it's in 40 to 48% of the population. So I'm still waiting for someone, I hope maybe somebody listening today can spur somebody on to do that study, because you can do it non-invasively, relatively non-invasively, with an optimal echocardiogram or ultrasound of the heart. Sometimes they're injecting, tiny bubbles to confirm this, but this can be tested for effectively non-invasively. You don't have to do a cardiac catheterization or any of those things. So I'm hoping that data will one day become available. So then if we move on to MS, multiple components within MS, of course, but remember, there is agreement. These people have excess inflammation in the brain, and they have a leaky blood-brain barrier. And both of those are probably tied together, okay? The blood-brain barrier, or the endothelium, will be injured much more easily if there's a relative lack of oxygen. So now you're hopefully seeing how a CCSVI component would tie in to that lack of oxygen in that region, okay? Because the body, like everything else, blood follows the path of least resistance. So if you've got a relative blockage of part of the venous outflow from that part of the brain, the fresh new blood from the heart relatively bypasses that area, okay, and goes to a different region. Consequently, that area is relatively starved for oxygen. And that was why Petrov's study helped confirm that principle. So if we see that those are components, anything that will reduce those microemboli, and the one we've talked about quite a lot was the microbiome, right? Because if you can optimally heal the gut lining, the likelihood of LPS, right? Lipopolysaccharide, which is the tiny outpouchings of dead gram-negative bacteria in the gut getting into the bloodstream. And this was a great paper in 2016 in the Annals of Neurology. I was at ISNVD in New York, and when I asked the question about was hypoxia one of the triggers for MS, he said it may be. This is a neurologist out of Louisiana talking, very well spoken, because he quoted Desai's paper, DESAI. And I talk a lot about this in the book because I shared it with Professor James because I visited him in Dundee, Scotland about a few days after the meeting in New York of the International Society of Neurovascular Disease. Sorry, what is ISNVD? And they talk about it in the paper, and they show reversal. They're able to trigger MS-like symptoms. It was in a rat model. They're able to trigger it by injecting LPS, lipopolysaccharide, which is the same thing that goes through our bloodstream all the time. And the higher that number, the more your whole body inflammation is. The lower that number, the much better off you are. So they injected it, triggered MS-like symptoms, and they were able to solve them. They put the rats at normal baric, meaning the pressure around us right now, at 80% oxygen for 2 days, 0 MS symptoms. Okay?
Great.
So it ties all the pieces together really quite nicely. Just as a kind of a little sidebar, most of you with MS know about EAE, experimental autoimmune encephalitis. And that was in a mouse model, which is still used today. If you give those mice that are affected with that hyperbaric oxygen, their symptoms go away too. But I much like the induction of the model with the LPS because that's much more closely to what happens in the normal world, in people everywhere.
Right.
So that's why the microbiome optimization help that gut lining heal. The LPS doesn't travel across, the gut lining, neither do all the other food components, which give you those food sensitivities. And all of a sudden, things start to heal up. And that's why they tie in really quite well together. So let's just see if we've got any other
We do have questions. Yeah. Why are people in the hospital with COVID-19 found to do better when they are positioned on their stomach?
Well, that's a tricky question. And I'm not an intensive care person at the minute. I mean, I have had my training and worked in ICUs quite a considerable amount. It's a real challenge to look after people when they're prone, which is on the stomach. So I would suggest maybe one reason is they're getting more of the gut contents are taken away and the lung is able to expand better and we get oxygen gas perfusion with the circulation in the lungs, just as it's much better sitting up. So that's the best I can give you for a reason why. But I know it's a challenge to work with them on their stomach for any number of reasons, for taking out the secretions and so on. And many of you have probably read, when you're on ventilator, when you have a tube down into the windpipe into the trachea, you're in a high-risk zone. 60 to 80% of those people die, unfortunately. Happily, it's only about 5% of the COVID people. And overall, there's at most only 20% ever need to go to hospital. 80% have them in pretty mild components. And just while we're talking about that, a nice study came out of the University of Stanford talking about the incidence in a county in Northern California. So they took people without COVID symptoms and they measured in the whole group, a little over 3,000 people, not unlike the 7,000 that they measured over in Iceland. And they found the incidence of COVID-19 in that group was at least 1.5%. So it's there in almost all places, and I think there's an awful lot more of it around us already than we realize. I was lucky enough, I had a great chat last night with a good friend of mine. This is a couple that go down, there's snowbirds in the winter, and they're gone several months in the winter, and they traveled up right at the end of March, and by the time they got here, they recognized that they probably had COVID-19. So they went through all the stories and the symptoms. So now my case experience is much increased by known COVID entities, but I think it's much more common, and I'm really happy that they're doing a lot more testing in all parts of the world, and they're even starting to increase it throughout Canada and throughout the United States. Because until we know how much is there already, we're not going to really know when to start to normalize things. But I'm really hopeful we'll start to normalize things pretty soon. So for heaven's sakes, let's please measure the antibodies, at least in our healthcare personnel and maybe in our grocery care workers, because those people are really on the front lines. They're relatively more risk themselves and their family. Let's give them as much information as we can. If they're affected, fine, let's give them a break. And the people that have already had it and now have relative immunity or antibodies to it, then they can pick up the load, and they feel much better about it because everybody knows where they are and they're just not sitting unknown at home.
Right. How long do you think the antibodies would last in a person?
The best guess, because of other viruses, probably a year.
Okay.
When you have it. It could well be more than that. It's extra complicated if you talk about a vaccine, because a vaccine doesn't tend to develop the same amount of immunity as having the illness itself. Okay, because it's some attenuation, and there's all those other parameters about vaccines. So our best guess is at least a year, and maybe lifelong, because in many viruses it is lifelong because it's a different part of the memory. It isn't quite the same as when you pump it up or irritate it with a vaccine, which you have to keep doing.
Right.
It is complicated by the feature of the mutations. Okay, because we know COVID-19 is mutating. It's doing it fairly frequently. That makes it an extra hack. Don't hold your breath on this vaccine because the virus is mutating pretty rapidly. So it's going to be an extra challenge. I think a more normal optimal would be the so-called herd immunity. It's reckoned that maybe 80% of the world will have it within a year regardless. So it's time to, sure, we flattened the curve. Now it's time to let more of the curve of nature blend in.
Okay, good to know. Next question. My CCSVI treated in 2009 from wheelchair to perfect. Miracle. Extreme heat sensitivity remains and fatigue. 2 stents placed. RIJ and azygos. Woke up perfect. Never looked back. Oh, well, that's a great comment.
So that's exciting. And I'm glad that your stint has worked out okay in the internal jugular, because part of our time we're not sitting and there isn't much flow, and that's reduced flow is a problem for clotting.
Okay, next one from Shelly. She says she had her CCSVI treatment in California in 2011. Her brain fog has all disappeared and never returned, but her heat tolerance is worse. Also, her walking is good, generally, although when I stand up, my legs take a few seconds to start walking. What do you think is the reason for my heat intolerance and walking? Thank you.
Well, I would suggest, Shelley, that you're still struggling with some of the components of MS. And my favorite, all the modalities that I talk about in my book, solving the brain puzzle, because it's a whole host of modalities. modalities from reducing your toxin intake, eating mostly organic food, probably getting off gluten and casein, and we haven't harped on that too much in this setting, but we will in the future days, because about a third of all the population have a hiccup or a problem with eating gluten and casein, which is the cheese protein in dairy. Okay, so the piece that I think that you could add in with best benefit would probably be increased oxygen, perhaps especially at night, okay, because that's likely when things are happening. I happily, with the modalities that I've done, and more recently it's been a whole series more of hyperbaric oxygen treatments because I'm lucky enough to have the access to it. But the studies of 30 years of MS people in Britain have showed that if people did their hyperbaric oxygen once a week, then often they could stay very status quo. Now, I'm really happy that yours has stayed status quo, but there's some suggestion you still have symptoms because it's affecting your initial walking and it's affecting your heat tolerance. And once you're well enough, the heat tolerance normalizes. I mean, when I used to work outside here in the garden in the summer, I was taking 3 showers a day easily to cool off, okay? Because heat tolerance was pits. And now I can happily walk 18 holes of golf and not be an issue because all of these things tie in together. So you need to find a couple more pieces of the puzzle. I'm really happy that CCSVI was such a large piece. And, we saw that at the time. A third did incredible, and some of them persisted forever. A third did some improvement, and then maybe didn't persist as well. And a third, it didn't seem to make very much difference. And that we find that like with many modalities, because MS is probably a multifactorial entity. Some of them repairing the microbiome is a huge piece, and it was a useful piece for me. Others, maybe not so much. So you need to sort all the pieces. Happily, almost all the interventions we do are non-surgical and at risk for us, so we can try them. So when I talk about enzyme therapy, I want you to listen up because it might be a useful piece for you to reduce these problems, because the particular enzymes I'm talking about will reduce that fibrin deposition, because remember, it's in almost all chronic illnesses, and you and I have a chronic illness. So if we can minimize that fibrin deposition, we may improve the flow and the oxygen transport through the endothelium. And each of these may counteract some of the chronic issues of, I call it the new MS, microvascular syndrome. I didn't coin the term, Professor James did, but he's my #1 favorite mentor of all time.
Awesome. Okay, well, that's it for questions, but I am really curious to hear more about these enzymes. So if you could speak to that.
Yeah, so it's time that we did. So we've known for a number of years that some enzymes really make a difference in the body. If you're older, now that I'm almost 67, it's likely I would benefit from regular use of digestive enzymes when I eat, because that really improves absorption, breaks things down, and I cheat. If I eat way too much, Thanksgiving, Christmas time, whatever holiday it is, I'll take a couple of digestive enzymes and I won't get the stomach upset, and I can get away with eating too much, okay? So that gets us into a mindset thinking about what's happening, because that improves the digestion in it. And the digestion reduces in a lot of us. I mean, it almost eliminates all the acid secretion if you're on a protein pump inhibitor because of heartburn and so on. And often the digestive enzymes would solve it equally as well. And I talk in the book how to taper off the protein pump inhibitors, because stopping cold turkey will not be a fun ride. It'll be very bumpy.
Exactly.
So that's part of the enzymes. The other enzymes that we know help break down the fibrin, the little tiny fibers that I talk being all through the body. The one with probably the most research behind it is nattokinase, okay? So that was pulled off Canadian shelves probably 3 years ago, and eventually they came with all the components, and they were able to make claims, because it says on my bottle here, cardiovascular health. Now, Health Canada would not give them a national product number to put on unless they provided the appropriate research to back it up. So we know that that is able to help break down the excess fibrin in the body. It doesn't turn you into a bleeder, which is good news. Okay. People that already have factor VIII deficiency and von Willebrand's, they're not in this group. But it is the 20 or 25% of excess fibrin. Remember, chronic illness or trauma or acute infection, i.e. COVID, or some other acute infection problem. So this one is suggested at 100 milligrams a day. So that's made in Canada. You can find it almost any health food store, and you'll find other versions, but it's nattokinase, N-A-T-T-O-K-I-N-A-S-E. And so we'll list this on the website, right? Mm-hmm. And the nattokinase, that comes from, and it says on the bottle, non-GMO soy with a particular bacteria which ferments it and breaks it down into this particular enzyme. So that's, one of the best studied. And the other one that I've, had interaction with in the last probably 10, maybe even 15 years, but more than 10, is Boloki. Okay, that's a little hard to see probably on the line, but it's BOLUOKE, which is lumbrokinase. Okay, so this came a lot out of the ancient Chinese literature because this is an enzyme based on the earthworm. Mm. And we happen to do some gardening and farming here, and happily earthworms in your soil, very good thing. How can they get through such dense soil? Enzymes. That's how they do it. So we're using that, and maybe that's not quite as well absorbed in the body, but at least 10% gets into the body. So some people will need even both of those. The easier one to start with, and I would suggest you start gently. Take one a day and for at least 2 weeks, and then you might do it twice a day. It lasts 8 to 10 hours in the body, although this one tends to be a slow release one, so hopefully there's some coming up over time. And some people, if they've got an ongoing problem of quite major, this might be a Lyme patient or someone with a chronic infective process and all these other problems, they may end up in 2 twice a day, and they might have to add in the Boloki and so on. But I think a really safe place to start, 1 a day, and get on it now. It is just possible it could reduce your baseline problem with excess fibrin before you get your COVID infection, and that might help keep you out of the intensive care group. Because ideally, we don't want to be in the intensive care group. We want to look after it at home and do well.
Right. So in the research that looked at the degrading capabilities of these enzymes, did they test them against any other types of enzymes? How did that go?
Well, I think they did, and they used some of the digestive enzymes because I don't know if you've ever noticed, many of us are drowsy half an hour after we eat. If I take digestive enzymes, I don't get drowsy because some of that drowsiness may be to leaky leaky gut problems, mm-hmm. and those components going around the body. One of those big ones might be LPS, okay, lipopolysaccharide. So back to healing that gut really matters. And in that fashion, many enzymes will do the same thing. The advantage of nattokinase, it's very specific to solve the fibrin problem. Mm-hmm. And lumbrokinase as well. It doesn't make a bleeding problem out of people. I'm still very keen, and people reduce their excess clotability with fish oils. At least 2,000 milligrams a day of EPA plus DHA. I mean, I only do now 2 things written for everybody should do, and one of them is fish oil for all of its host of benefits, but one is relatively reducing the clotting cycles somewhat. And the other, of course, is vitamin D. Vitamin D alone is very important for endothelial and blood health and all the cardiovascular issues that it supports. It improves cardiac contractility and many other features.
Right. Could you also eat natto? Would that contain enough nattokinase, or?
It probably would. It probably would, except we don't get it standardized. And,
Right.
you know, I guess I'm old school enough. I'm lazy and I'm not big on soy flavors. And so,
Right.
but if people can find natto and enjoy it, good on you. I mean,
Yeah.
I was challenged by my son. I was visiting him in Japan. He said, Dad, I'll bet you can't eat fermented beans at breakfast tomorrow. Well, I got through them, but once was enough. You know, I proved that I could, but well, maybe because I hadn't had it since I was a small kid, but as a small kid, maybe I'll do well. And maybe that's one reason that the Japanese have done better with COVID than many places.
Yeah, exactly.
Yeah.
Tessa is asking, where can I find nattokinase? Most health food stores do carry it. I've even seen it in some grocery stores. You can also get it from online supplement dispensaries. I recommend not purchasing on Amazon if you can avoid it. Try purchasing from actual health food stores or from stores online. Roger is asking, he took digestive enzymes for a few weeks, but it always caused diarrhea. Any ideas why? There are a lot of different types of enzymes. So there's the chance that you were reacting to the specific type of enzyme that you were taking. So there are enzymes that are derived from microbes or fungi. Some people won't tolerate those. There are enzymes that are derived from certain food elements, so maybe papaya or pineapple or something like that. Maybe if that's what you were taking, maybe you don't tolerate pineapple. And there are also enzymes that are actually specifically from pancreas or something like that. So, I mean, it would really depend on the type of enzyme that you were taking.
And the one that sometimes throws people a curve, some people, if they don't have enough bile, and a common problem would be after a gallbladder removal, cholecystectomy, they might do better with something with ox bile or some other version of bile in it. And that might be one of these triggers for the diarrhea too. So it's a matter of mixing and matching and then finding out what are the common elements to solve a problem. For the constipated people of MS, because that's 70%, you know, it might be a relative holiday. Boy, I've got relatively loose bowel movement. So it's a continuum. I get that. And nobody wants to spend all day on the toilet, which happens in 1 out of 5 COVID cases. Okay? Diarrhea, belly cramps and stuff. Because remember, COVID-19, and this is worth mentioning, we all know that it affects the ACE2, and that's how it gains access to the human cells. ACE2 receptor, angiotensin converting enzyme. And that is dominant in the alveolar cells inside the lung, but also throughout the endothelium or inside the tiny blood vessels throughout the body. Okay? So it's everywhere. So that's why, you know, it's pretty important. Listen to this fibrin problem because it is a rate limiting step to make a difference potentially to you going to ICU or not, but it may make a real host of difference to improving your general well-being, whether it's a chronic fatigue problem or whether it's an MS or even perhaps migraine headaches. And even to those, you know, that have had some benefit with CCSVI, and maybe it's worn off, or maybe they're just not completely better. CCSVI, to me, is the very real deal, but it's not a silver bullet for everyone. It is for a few. Great.
Okay. Well, we're coming close to the end, so maybe we should just wrap it up and you can kind of hit the main points that we covered today.
Sure. So, yeah, thank you. Ideally, you would say what we're going to say. And so we kind of introduced that. What I tried to do was tie in COVID, coagulation, along with headache, MS, and CCSVI. So I'm hoping you see the thread through them all because each of those are a vascular problem, and supplying oxygen is why we need the vascular problem and the flow through it so that it all comes together. And remember that the fibrin can create a sludge element or a thickening almost of the wall of the endothelium, so the oxygen transport through that endothelium is reduced. And you may be able to counteract that with the nattokinase. And the one I'm holding up for you has an NPN number. So if you purchase one in Canada, I would suggest one with a national product number because that is mean it's qualified by Health Canada and it has gone through rigorous production and it's reproducible. Otherwise, you're going to have a trial and error entity. So you get to decide.
Right. Okay. Well, if that's it, maybe we will sign off for today. And if you guys could please share the video with anyone who you think it might benefit, that would be fantastic.
And if they don't do Facebook, and most of my siblings don't, okay, please send them to drbillcode.com under blog. There's many listed there, including the podcasts we've done elsewhere.
Yep. Okay.
Have a great week. We'll see you on Thursday.